morning, my colleagues. Let's start our CNS Viva session. Candidate 1, can you request control, please?
Okay. Requested.
This is a 15-year-old female patient presented with a history of fever for 5 days, followed by altered sensorium, no rash. Go on.
Okay, so I'm presented with MRI of the brain, axial T2 weighted images of a 15-year-old female with fever and altered sensorium. I would like to have a general look before starting my comments. So there are multiple high T2 signal intensity foci seen distributed throughout the brain, mainly involving the white matters and the subcortical fibers on both temporal and frontal lobes, as well as the brainstem. There is no hydrocephalus, no mass effect, no inter or extra-axial collections. So these lesions are not associated with perilesional edema. I would like to correlate these with the other sequences, namely T1, diffusion, post-contrast, and ADC.
Which one do you need?
Okay, firstly, I would like to take the flare.
Please announce. This is flare.
Okay.
Go on.
Okay, so the flare confirmed the presence of these multiple foci. You would like to correlate these with the T1.
Okay, ST1.
Okay, so on the T1, the lesions are iso to the brain matter, so they are not hemorrhagic. I would like to correlate with the diffusion and ADC to check for any evidence of diffusion restriction.
This is diffusion.
Okay, so these foci are bright on the diffusion. I would like to correlate with the ADC to confirm the restriction.
It is low in EDC.
Okay, so
Slow.
these lesions show diffusion restriction all through the brain. I would like to check the post-contrast for enhancement and the susceptibility weighted for evidence of hemorrhage to look for the blooming artifact.
See, in real exam, the examiner will not give you too much sequence like this, especially in very clear cases or especially if the pathology is clear. Okay, but however, I will give you in our session.
Okay,
What do
so
you
this
think?
is the susceptibility weighted artifact, no blooming artifact. So again, these foci are not hemorrhagic. My differential diagnosis till this point, bilateral, multiple, diffuse, deep and subcortical white matter lesions could be infectious given the history of fever. These could be due to sort of encephalitis. The patient is 50. Yes. Other possibilities could be it's not typical for multiple sclerosis. That's mainly becoming periventricular.
Yes.
Yes. Other possibilities could be demyelinating.
Okay. What do you
So
think? Do you think demyelinating disease would be like this?
not typical. That's mainly deep white matter, again, periventricular. So I would
Not.
like to.
What is the distribution? The distribution is the key in this case.
Okay, subcortical, mainly subcortical or gray-white matter junction.
Yes.
I would like to correlate with any history of trauma. These, however, they are not
Do you
hemorrhagic, not showing
remember?
blooming
Do you
artifacts.
do you remember the
Fever,
patient history? So what do you
fever.
think? What do you think? The patient
So
get fever, and after 5 days, this is his or her MRI. What do you think?
So I would like to go with the inflammatory or infectious processes.
What else?
I would like to go with encephalitis.
What
Could
else?
be viral.
Do you think the distribution of encephalitis will be rather symmetrical like this and looks like something not random? Look well organized in a specific subcortical location. Does it mean for you encephalitis or something else? Hello?
Okay.
Yeah.
Yes, yes. Okay, so I would be thinking about systemic disorder, giving the bilateral
Okay.
symmetrical appearance in this gray-white matter junction. Could
Mm-hmm.
be like multiple small abscesses becoming hematologically spread
Abscesses. Okay. Look
for
at the
any
post
remote site
contrast.
of infection. Yes.
Look at the post contrast. What do you think?
No significant enhancement.
So, are you insist in your differential as abscesses
No, abscesses should enhance and be surrounded by edema.
and the peripheral enhancement? So, what
Yes.
else? What
No,
else?
no enhancing meninges on this case as well. Okay, so could be like infarcts,
Okay. Why?
showering infarcts,
What is the source?
infective endocarditis, or
Mm-hmm.
atrial thrombus, shunt.
But do you think that in showering emboli they will only in the gray white matter junction?
Not typical.
Yeah, showering is more random, extensively random. Okay.
Okay.
This patient
So
have fever.
cysticercosis maybe.
No, no. See,
Okay.
see. Now we excluded infectious nature. Okay.
Okay.
Okay. And you suggest infarction. What is the cause of infarction here? The examiner is helping you. So don't shift from the last result.
Okay.
Okay. What is the cause of infarction? You suggest showering emboli. Then the examiner answer you showering emboli is more extensively random. What else?
Okay. So could be um, showering emboli bilateral symmetrical. I would be thinking about
Yes.
in internal carotid arches,
Your
like
voice, your voice is
yes,
muffled.
yes,
Dr. Nahum, your voice is muffled. Hello?
yes, yes. I can hear you. So could be internal carotid arches,
Yes. Mm.
thrombi, or
Hello?
yes, sir.
Look here at the carotid.
Anterior.
Yeah.
Okay.
Do you detect any abnormality here?
Okay.
Mm. Tell me,
Honestly, I couldn't pick any abnormality.
what's your final diagnosis? Hello?
Yes, yes.
What's your final diagnosis?
Okay, I would be going with infarct. However, I would like to search for the cause. I would like to go for the MRA
The
and
MR. Mm. If I
refer the
told
patient.
you, if I told you the MRA is normal, okay? What do you think? Maybe normal here. Anyway, it was a very difficult case. The answer is here. This patient has fever. So after the fever, he developed this small bilateral, nearly symmetrically distributed infarcts. So he has some vasculopathy and almost peripheral. Okay. What happened here?
Okay.
Thank you, by the way. What
Thank
happened
you
in
so
the
much.
in the actual exam, the examiner will not talk like this, will not give more than I think 3 seconds at most. But here we are enriching our speech. We are trying to discuss as deep as possible. Leave the mouse, Dr. Nagam, please. As
Okay.
much as possible. I was aiming to go in more and more differential diagnosis, how to exclude, how to include. What happened here? The patient has fever, and really, this is a very atypical case. Really, what happened? Our doctor look here. She finds this all abnormal peripherally, cortical and subcortical signal intensity. Okay. Then she asked for T1 to rule out hemorrhage, but you make mistake. You ask T1 and susceptibility. The examiner will not give you 2 sequences to rule out hemorrhage. Okay. She get this
Okay.
one. Give the mouse, please. She got uh, got this diffusion. There are nearly symmetrical peripheral at the area of corticomedullary junction. Okay. When you find something very symmetrical like this, think about something systemic or generalized. Okay. Why I refuse showering emboli? Showering emboli, some infarction here, in the cerebellum. But this patient, this distribution looks like affection of a specific part. Okay. After infection, we must think about vasculopathy or Adams. When I revise this case, the first thing, honestly, come in my mind, this may be abscesses. So I have a look at the post contrast. No, any enhancement even at the diffusion restricted areas. Okay, so this is not abscesses or even infection. Okay, the next differential may be Adam, but Adam is, I think, more larger, not specifically involved the corticomedullary or the gray-white matter area. It is almost involved the white matter. So Adam is not possible. So finally, it was a vasculopathy. Vasculopathy. Take a home message. Anything at the junction between the cortex and the white matter. Think of systemic, whatever. Think something systemic, whatever the systemic issue. Do you remember before when we was differentiate a hyper signal here in T1? One of the differential was systemic infection like cysticercosis, systemic hemorrhagic metastasis. So the white matter and the cortex junction is a region for systemic pathology. Okay, especially when it is nearly symmetrical or symmetrical. Thank you so much. Again, it was post-infectious vasculopathy. When you find multiple small infarction, uh, either either randomly distributed or symmetrically distributed in the brain, think in vasculitis. Okay, this vasculopathy is a type of vasculitis. Okay, my colleague. If somebody told me, doctor, it is a vasculitis, it may be acceptable. Okay, my colleagues, thank you so much. Next candidate. The first candidate overall is unlucky because the first case usually is the typical case in my sessions. Thank you so much. Next candidate.
Yes, sir.
Welcome. This is 70-year-old male patient presented with gradual short-term memory problem in the lower limb weakness. Request control, please. Could you request control? Hello? 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 Candidate 3, are you ready? Because candidate 1, can you hear me? Hello? Candidate 3, Dr. Nagam, where is candidate 3?
I'm with you. I'm with you, Dr. Ram.
Candidate 3?
Yes.
Yes, could you request control, please?
If you can help me, I have a problem with requesting control. If
No
you can give it.
problem. Yeah. Did you hear the history?
No.
Doctor, this
Yes.
70-year-old male patient presented with problem of memory and lower limb weakness. Go on.
I'm presented with axial MRI T2 sequence of the brain.
You can stop me at any slice of interest.
Okay. I can see abnormal signal intensity centered upon the left lateral ventricle, extending mainly to the frontal horn, displacing the midline structure to the right side. I can see related dilatation of the left lateral ventricle and the third ventricle. Regarding the signal, I can see heterogeneous signal with streaks of hypointensity. If I can see the T1 sequence of the patient,
Yes, T1.
I can see hyper intense and hypo-intense areas.
Yes.
Concerned that this is extraaxial intraventricular space occupying lesion with hemorrhagic component.
Okay.
If I can revise the sagittal cuts of the patient,
This is sagittal. What do you
I
think?
can find that the lesion is extending to the floor of the frontal fossa.
Not frontal, anterior cranial fossa.
And anterior cranial fossa.
Mm-hmm. What else?
I'm suspecting. I can see the lesion displacing or compressing the suprasellar cistern contents downward.
Mm-hmm.
I can identify the infundibulum.
Yes. What's your diagnosis, doctor?
I'm concerned that the lesion is intraventricular lesion.
Yes.
My differential diagnosis will be choroid plexus lesions or
Look at this slice, please. What happened here?
the lesion is pointing towards the left orbit.
Yes. What else?
And displacing the left frontal cortex laterally. This
Okay.
may
Okay.
be
What's your differential diagnosis?
my differential diagnosis will include the suprasellar lesions. Regarding the signal voids seen at the lesion, I would suspect the possibility of craniopharyngioma.
What else? Hello?
نعم.
What else?
The craniopharyngioma and
What else? See, what is this?
optic optic this
Yes.
is
What is this?
optic nerve glioma
1
or
second. What is this?
stranding fat stranding around the
Fat. Fat. Okay.
fat.
What is it?
The signal of fat.
Does the signal looks like this one or not?
Yes, yes.
What do you think?
I
Look.
think this could be dermoid lesion.
Okay. No, no, leave them. Okay. This is fat containing lesion. Okay. What else? What happens for this lesion? Look here, please. Look here.
I can
Look at
see
the.
small foci of small hyper intense foci scattered
What does it mean for you?
along the. This is pointing to rupture dermoid content.
Yes. Yes. Rupture dermoid.
I can see the hyperintense foci along the basal
Okay.
cistern, ambient cistern, and
What is your next step?
my next step is urgent referral to neurosurgeon colleague.
Why? Why?
Uh,
Why? What is the complication of rupture dermoid, intracranial dermoid cyst?
increased intracranial tension
What else?
and hydrocephalus.
What else?
Uh, anaphylactic reaction.
No, no.
No.
Did you hear about chemical meningitis?
Yes, chemical meningitis. Yes.
Yes, okay.
Okay.
See, the examiner will not show you something like this. Very easy. Look, very easy to detect. Okay, what happened here? This is fat containing lesion. Okay, and if we look here, there are
Can see.
foci of low signal, fat
Global.
signal, and even here.
Mhm.
So overall, when we are dealing with dermoid, thank you, doctor, so much. When we are dealing
Thank you, Dr.
with a high T1 signal like this, before you decide, this is hemorrhagic or fat, at least compare this one with any nearby fat, like this. The hemorrhage will not be bright like this. Okay, and even the patient is lying in his occiput, and the occipital bone is down. So by gravity, the which is in top is the fat. Okay. Next one. Next one. Look here. Very characteristic. The hemorrhage. Suppose this is you are in doubt. This is a hemorrhagic lesion, something like this. When the hemorrhage spread in the subarachnoid space, he didn't spread like separate globules like this. This is very, very characteristic of the fat. Okay. Number three, if you got here the post contrast, and this is very good, 100% sure sign, because post contrast must be fat set. Look here. Look. What happened? Complete suppression. So you are sure this is rupture dermoid. This is dermoid. This is the most important. Okay, because when you are dealing with a hemorrhagic lesion, it is a big difference and not emergency. But if you detect this is a rupture dermoid, an action must be taken now to avoid chemical meningitis and other complication. Okay. One question, doctor. Doctor, if you find fat globules here in intracranial, okay,
Mhm.
and you didn't find the dermoid cyst or any fat-containing lesion here in the brain or intracranial. What is your next step?
intraparenchymal fat.
You find intracranial fat globules like
Mhm.
this, and you can't find any intracranial fat-containing lesion. What's your next step?
I don't know.
Okay. Sometimes the dermoid cyst is in the spine. Okay.
Mhm.
Either cervical
Yeah.
spine, dorsal, whatever, and it get ruptured. Some globules go to the brain. So when you are dealing with something like this, fat globules, and you are in doubt this is ruptured dermoid, but I can't find the dermoid cyst intracranially, ask the examiner for spine MRI. Why? Because specifically or especially cervical spine, because the dermoid cyst may be at the cervical spine and it get ruptured, and it became the source of fat globule. Or the opposite, you are dealing with a spine MRI, you find fat globule, and you didn't find any source of it, fat containing lesion. Ask for higher levels MRI, either brain, either cervical, like this. Okay? Because all the
Okay.
spinal axis is CSF is interconnected. Thank you, doctor, so much. What is the diagnosis again and
Thank you,
again?
Doctor.
Rupture, rupture intracranial dermoid. When you are dealing with high T1, if you get the CT, sure you will get the answer because it is very intensive. But when you are dealing with high T1, high T1 lesion like this, think twice, especially when there are the high T1 here, independent in the most highest level. So it means that this is of the lowest density. So it may be fat. Thank you, doctor, so much. Candidate 2, are you here with us again?
Yes, sir. I can hear you.
Yeah. Can you request control?
Yes, sir.
40-year-old 40-year-old male patient presented with headache. Go on.
Okay, sir. I'm provided with the multi-sequential MRI of brain uh,
Yes.
of a 40-year-old male presented with headache. First, I would like to see axial T1 MRI.
No, no, no. See. Don't choose something other than the examiner given to you.
Oh, okay, sir.
Okay? Yeah, go on. Mm. Scroll this one.
Yes,
Yeah.
sir.
Yes, yeah, go on.
Uh, okay, I can appreciate a linear T2 hyperintensity scene
Mm-hmm.
ex extending from the left lateral ventricle.
Yes.
Okay.
Mm.
Sir, there's a problem with the, I think, scrolling. Can you scroll for me, sir?
What?
Sir, there's a problem with the remote. I cannot scroll properly, sir. Can you scroll for me, sir?
Okay. You can stop me at the slice of interest.
Yes, sir. Okay, sir.
Mm.
So I can appreciate a linear T2 stir hyperintensity extending from left lateral ventricle and
Mm-hmm.
periventricular region. Uh, for further, I would like to see uh, GRE sequence.
GRE sequence. Okay. What do you mean by GRE?
That's a gradient echo, sir.
Gradient. If we didn't have gradient,
Susceptible.
what do you need?
Sir, sir, I would like to see post contrast T1.
This is GRE. Go on.
Okay, sir, I can appreciate a linear peripheral area of susceptibility. I would further like to see, sir, axial post contrast T1.
Okay, this is post contrast.
So, sir, I am seeing there's a linear hyperintense, actually enhancing structure extending from left lateral ventricle reaching up to the uh, cerebral hemisphere, cortical sulci. My concern for this patient is DVA, developmental venous anomaly.
Yes. What is the name
I
of this
would,
sign, doctor? Doctor,
sir, I cannot.
what is the name of this
Okay, sir.
sign?
Sir, actually, I can't. I don't know the name of this sign, sir.
What is the most common association with DVA? Or DVA
Sir,
commonly is an association for something else.
sir, there's a common association with cavernoma, sir.
Yes. What is your next step?
Sir, I would like to see the GI gradient susceptibility artifact to imaging to rule out any presence of cavernoma or bleed. For further, I would refer this patient to a neurosurgical team for
Yes.
uh, further, sir, management.
Yes. Okay. What is the most common complication of DVA?
Sir, sir, one complication is sir bleed, sir, bleed from the vessel, sir, intraparenchymal or subarachnoid bleeds. The other possibility is AV malformation, sir.
No. Bleeding, okay, but AV malformation, I didn't hear about it before. Thank you, doctor, so much. What happened here, my colleagues? There are signal abnormality here. Okay, it looks like linear and branching. So he did very well when he asked for gradient, but actually in gradient, this is the not typical appearance of DVA. Then he shift or ask for post contrast. It is the cabutamidose sign. Very important to tell the examiner as much as possible buzzword related to your case. What happened? This is capita mediosa. What is capita mediosa?
Sir,
Multiple small uh, venules uh, collected in one larger vein. And it is better also to tell the examiner, doctor, it looks like this drained to like this one vein here and it drained here. Actually, this DVA start here from the subependymal here, and collected here. Okay, and finally, this is the draining one. You should go up. No, not going to the cortical vein, but it looks like go down, down. I think if you follow this one, look here. If you follow, this is angio, MRA of the neck, but it have a one sequence here. See, follow this one. It almost to go to the left cavernous. Look, this one. It drain in the cavernous sinus. Anyway, at least try to mention as much as possible buzzword and as much as possible details about your pathology. Look here. This is the draining vein. If you follow it, look. I think look, it is directed to the cavernous sinus. Okay, my colleagues, because
sir,
all the DVA started intraparenchymal and must go to a draining vein. This draining vein must end in one of the dural signs. Okay, my colleagues, I want to give all of you a bit about the venous system of the brain because most of us are not This is not familiar for us. What happened for the brain venous system? We have originally two systems. This dural sinuses, okay, dural sinus, superior sagittal, inferior sagittal, transverse. All of us know this system. Then cavern. And what else? And directly to this, sorry, where is the gradient? This is the gradient. Directly draining to this dural sinuses, look here, cortical veins, cortical veins, okay? This cortical veins named superficial system, okay, my colleagues? To this dural sinuses, all the cortical and the superficial systems are drained. There are many and many names of the superficial system, like vein of Labbé, vein of Rosenzel, whatever. Okay. What about the deep system? The best sequences to see and to delineate the deep system is SWI. Okay. Here I will show you something. Here, look. SWI is the best. And SWI is the origin of the venography of the brain. Okay, I will show you something here as much as possible in this gradient, but this is not the best. The deep system start here subcortically. Then the veins go perpendicularly to the ventricular system. Okay, this, look here, this is vein, this is vein. This is called intramedullary vein. So we start subcortically, then go vertically or perpendicular to the ventricle by the or the medullary veins. Then this all medullary veins collected subependymally. Okay, subependymally. And after that, all these deep veins, there are three major veins came here from the ventricle and collected at the venous angle here. The venous angle is just below here, below the splenium and the pineal body. Okay, here my colleague. This venous angle, this one. We all of us know the vein of Galen. The vein of Galen consisted of two internal veins. Okay. The two internal cerebral veins, each one formed of the three major internal veins, three major deep veins. Whatever the name, if you forget, at least you know the main idea. One of these three are lenticular, the other is choroidal. I think the last one is ependymal, something like this. But at least now you know that we have two systems, superficial and deep. All the superficial looks like the cortical veins, which drain into the dural sinuses. Then the deep one is the medullary, which drain perpendicularly or go perpendicular to the ventricle. From the ventricle, collect in three veins, each of these three veins, one right and one left, forming right internal cerebral and left internal cerebral, both internal cerebral, finally forming the vein of Galen. Vein of Galen connected this inferior sagittal sinus to form the straight sinus. Is it clear for all of us? Because this is important. You may be asking in the exam. Maybe. Okay. Next candidate. Hello.
Hello. Hello.
Yes, welcome.
Hi.
Doctor, this is 30-year-old female patient presented with right-sided paresthesia.
Okay, I'll ask for control.
Ask.
One second.
Yes.
Yeah. I requested.
Yes. Go on.
Yeah, okay. 1 second. Just taking some time. Yeah. I'm presented with a sequence of the brain. It's just taking some time to scroll. So I will be scrolling to detect any abnormalities. I'm scrolling from upwards downwards now. This is a sequence that is usually used to detect for more precise detection of the cranial nerves and cranial nerves pathologies, since the patient is presenting with trigeminal neuralgia. I am now looking at both trigeminal nerves. Yeah, it ended. Okay. Sorry, I'll go back. Um, I cannot really.
What is the name of this sequence?
This is the cis sequence, CISS, the thin cuts of the T2. Yes, now I'm
Okay.
seeing both trigeminal nerves. She's complaining, I'm sorry, of right or left neuralgia. Was it mentioned?
Right.
Right neuralgia. Okay. So I can now see, I can see the right trigeminal nerve. Here it is. It should be, and this is the Meckel's cave. The Meckel's cave on the right side is slightly narrowed. Okay.
Did you detect any obvious pathology here? Yes or no?
No, I didn't.
خلاص, ask for another plain MBR. Ask
Okay.
for a help.
Yeah. So yeah, I didn't see any abnormality, any striking abnormality in this sequence. So maybe if I can have a look on other sequences such as T2 or flare.
Tito or flare. Okay. See, to save your time, look here, please. Why? See, doctor, you start with siest or
Yeah.
fiest. Both are, by the way, my colleague, both are fluid sensitive, high resolution T2 with something looks like 3D. It is highly specific for CB angle and trigeminal to detect this very small structure. Okay, so it is logic after that you see the axial of this fiesta or siesta, and both the name are the same, but one for Philips and one for Siemens, something like this. To ask the same siesta but in another plane. But why? Because if I give you like this flare,
Yeah.
what will you do? Nothing. Why? Because this is low resolution. So
Yeah.
we must ask for other high resolution. Go
Yeah.
on, doctor.
So in this, yeah, it is scrolling. Yeah, good. Will you be scrolling or should I scroll?
Roll. Yeah, go on.
So I'm now 1 second. It's just too slow in scrolling. I'm sorry. So I'm now scrolling at this coronal cis sequence to for right trigeminal neuralgia. Um, this is the region of the sella. Here is the region of the. Sorry, it's just taking time to scroll. Yeah, here is the region of the trigeminal nerve. I can see there is asymmetry between both sides. The
Yes.
trigeminal nerve on the left side is seen, okay. However, it cannot be really detected on the right side. That is, the CSF signal is replaced by a slightly hypointense signal compared to the CSS. So I'm suspecting there is something at this region. And
Stop here. No. 1 second. Where is the right? Leave the mouse. Where is the left trigeminal? Show me. Left.
this one, this is the left
Are you sure?
trigeminal.
Are you sure?
Uh,
Leave the mouse. No.
I'm
I
scrolling
give
to.
you.
Yeah, okay, sorry. Yeah.
Leave the mouse. Leave the mouse. Here. Where is the left trigeminal? Show me by the arrow, please.
I think this is the left trigeminal and this is the right trigeminal, and the right trigeminal seems to be smaller in size compared to the left trigeminal.
Doctor,
Yes.
see? Use because I don't know which. Okay, use this one. Show me. Make a circle around the right and the left.
I mean, here this is the left and this is the right.
Okay. Okay, what happened?
So I can see that the right trigeminal nerve is smaller, is attenuated and smaller than the left trigeminal nerve, and the CSF signal around the right trigeminal nerves appear to be slightly hypointense compared to that around the left nerve. So I'm suspecting like right trigeminal nerve atrophy, but I cannot really detect the cause. I mean. There doesn't
Okay.
I cannot really detect any lesion such as trigeminal nerve schwannoma. Nothing is apparent. That's why I asked for the T2 and flare, because the lesion may be apparent on them. But and I also checked for any abnormal vascular loop related to the trigeminal nerve, because
Did
sometimes
you find
there
any abnormality?
there is this vascular loop here. I would like to trace it. If it touch the trigeminal nerve, it may be the cause. If it is compressing on the trigeminal, it is closely related to it. It is closely, yeah, and it is not found in the other side. So yeah, this is probably a vascular loop. It's likely to be. I would have liked to trace more, but it's likely to be a branch of the ICA. It compresses the trigeminal nerve at its origin, resulting in atrophy of the trigeminal nerve and explaining the trigeminal neuralgia.
Okay. What's your next step?
My next step, I would like to have a look on the other sequences again to exclude any major abnormality or any lesion. If everything was normal and this was only the finding, I will confer this finding to the ENT. At ENT,
Thank you,
yes.
doctor. Thank you. I think this is not the icon. I think this is the superior cerebral artery. Okay.
Yeah. Okay.
Thank you so much. Why I
Thank you.
bring this case, my colleague? Why? Because it is not familiar to us. This is the axial 3D fiesta. Like I said before, high resolution fluid sensitive, dedicated for the cranial nerves, special CPI and the trigeminal. What happened here? The complaint from the beginning is a trigeminal complaint. If you look here, there are some asymmetry. The right looks like reduced in caliber, okay? Okay, but not clear, not very obvious. So your next step must be something, another plan of the fiesta. Here, okay, what happened here? This image is very easy and very difficult in the same time. Why? Because it is concentrated here. If you know or if you guess this is the trigeminal, this is the trigeminal, you will take the full mark in this case. You will get it. But if you confused, you will lose it completely. That is why I bring this case. What happened? There are structure here and structure here. And I'm searching for trigeminal abnormality. So there are asymmetry. It looks like, try to guess. This is a trigeminal but atrophied. This is good trigeminal. What is this here? Something above here and not here. Follow it, please, here. Follow. Follow this structure. Look. Look. It is curvilinear. And if you follow again and again, look. See? Vascular loop. Why this is not ICA? ICA related to CB angle. Nerve, it may entrap, indent, abutting the cranial nerve number 8 and 7. But here we are very far from ICA. ICA is here. ICA loop entrapment related here. Hey, this is ICA. This one. Okay? This
Yes. Okay.
ICA. This one. Okay? But yeah, but anteriorly and superior, because the trigeminal, see, the trigeminal is more superior. So we are thinking about the superior cerebral. Look, this one, the superior cerebral.
Yeah.
So it is indentation by the right superior cerebellar artery causing trigeminal neuralgia and atrophy. Okay, my colleague, the name of this sequence is fiesta or siesta. Okay, fiesta or siesta. Thank you so much. Next candidate.
Hello.
Welcome. Leave the mouse, doctor. Last candidate. Doctor, request control, please.
Okay.
This is 45-year-old female patient complaining. She originally is an alcoholic patient, presented to the emergency department with left-sided weakness and facial drop. By the way, you can't tell any patient you are alcoholic. This is a judgmental language, okay, and not acceptable in UK or any English-speaking country. Instead, we tell and we can't use the term patient. Mr. We can what we can say. Mr. X use like 5 units of alcohol per week. This is non-judgmental language, and it's very important. Very important, by the way. This is an OET information, but this is a really practical situation in the life. So we must not use judgmental language. Doctor, this patient presented with facial drop and left-sided weakness. Go on.
I'm presented with MRI of the brain axial T2 sequence. I will scroll through the images before giving my comment.
Yes.
It's not scrolling. Okay. Sorry, I'm having problem with the scrolling. Can you scroll for me?
Yes. Leave the mouse.
Okay.
Stop me at a slice of interest.
Okay, so the striking abnormality I could see is there is high T2, two intermediate signal at the right basal ganglia, surrounded by area of higher T2 signal, with mass effect in the form of effacement of adjacent cortical sulci. However, no midline shift could be detected, just slight midline shift towards the left side, with no dilatation of the ventricles. Okay,
This is
a
diffusion. This
Yes.
is diffusion.
Okay, this is diffusion sequence appears to be center
This is the EDC.
restriction.
Yes.
Yes, so there is true diffusion restriction centrally.
This is the post contrast. Okay.
Okay.
So what do you think?
So just faint enhancement in post contrast phases. However, I would like to compare it with the T1 to see if how the lesion
No
actually.
T1. The patient after 9 days repeated the MRI due to severe deterioration. What do you think? This is T2.
Yes.
This is
So
diffusion. This is post contrast. What do you think?
So now the lesion became bilateral in both basal ganglia with similar signal abnormalities, which is high on T2 with diffusion restriction and marginal enhancement. So my first differential would be abscess, but consider that it's progressing and becoming multiple. And the patient is worsening. He doesn't have any fever.
No. Hello?
Yes, sir. Maybe. So bilateral brain abscesses.
Yes.
Maybe fungal infection.
Why?
Because it's high spreading.
Further deterioration.
Sorry?
After some days or so, this is the follow-up MRI.
Now there is midline shift toward the right side. I think with more ring enhancing lesion appearing.
What's your final diagnosis?
So this is maybe systemic infection with multiple abscesses in both basal ganglia.
Okay. What do you think? This is bacterial, fungal, viral infection?
I think this is more aggressive, so I'm thinking fungal.
Yes. Does the patient has any
Because
background that favor your diagnosis, that support your diagnosis?
maybe he is because of the alcoholism that would make him more immunocompromised.
Brilliant, doctor. Brilliant. Cerebral mucormycosis, which is aggressive fungal infection. Really, really, you impressed me. It was the case of today, this one. This first time for me to see a case like this. And I think for most of you, what happened here, signal abnormality here, that is faintly heterogeneously enhanced, but centrally restricted. Okay? The restriction is more central. Frankly, till this stage, it is not obvious is this something tumoral or infectious. Okay, but the follow-up, especially here, there are no obvious ring enhancement or marginal enhancement. Looks like also here maybe something malignant. But in the second MRI, it start to be very clearer, more clearer than before. What happened here? Marginally enhancing lesion bilaterally with central enhancement. Infection. Infection. Okay, my colleagues, very important. Look here, most of the restriction is central, but here it is marginally enhancing. The doctor did very well when she told us, as it is very aggressive and rapidly progressive, it looks like something fungal. Specifically in background of alcoholism, it means the patient is immunocompromised. I think this patient mentioned here or not, he have AIDS or not. Anyway, the fungal infection is very common in HIV and in any other patient who is immunocompromised. Again, it was a cerebral mucormycosis. Mucormycosis is one of the very aggressive fungal infection. Thank you, doctor, so much. Next candidate. My colleague, in my sessions, I'm trying to cover as much as possible atypical cases. Okay? If you answer, this is very good. If you didn't answer, this is not bad. Why? Because this is most of the cases are incredible, really. So the aim of the session is to update our knowledge, to take some lessons, learning some lessons, and to learn how to think. The most important issue that the examiner is evaluating during examining you is the way of your thinking, is your procedure, okay? This 30-year-old female patient presented with headache and papilledema. Next candidate.
Yes. Assalamu alaikum, sir.
Alaikum salam. Go on.
Yes, sir.
Go on.
Okay, so sir, you are scrolling, or shall I
No,
scroll?
scroll.
Okay. So I'm provided with Excel T2-weighted MRI of a 30-year-old male patient who has presented with bilateral papillary edema. So it is not working, though I have requested for the control.
Yes.
So could you please scroll for me?
Yes.
Okay. Sir, okay, I'll look at the images first. So this, I cannot see any obvious abnormality. The sulci and gyral side slightly prominent for the age of the patient. I'm looking at the optic nerves bilaterally. So there is mild prominence of the perioptic CSF space. And
Yes.
Other than that, I cannot find any lesion. The cavernous sinuses are not enlarged, and pituitary fossa is not expanded.
Okay.
So there is some suspicion of hypointense area along the left-sided canalicular portion of the orbit. That
Don't
is
worry about
concerning.
it. Look here,
Okay.
please, doctor.
So this is T1 weighted sequence, and I'm looking for any lesion. I cannot see any obvious lesion other than the sagittal sinus appears hyper intense.
Yes.
Loss of signals of flow-wide signals involving the superior sagittal sinus.
So
So I would, sir, I'm thinking of venous sinus thrombosis, so I will go for
okay,
contrast and MRV. Mm, yes,
what
sir.
happened?
Yes, sir. There is thrombosis and there is filling defect involving the superior sagittal sinus.
Yes.
So there, other than that, I cannot see any lesion, any hemorrhagic lesion within the brain parenchyma. There is no tonsillar herniation.
What's your final
Um,
diagnosis?
so this is a case of acute cerebral sinus thrombosis, venous sinus thrombosis. So this patient requires immediate referral to the referring physician for anticoagulation and follow-up imaging. Though I
Yes.
would also advise, yes, sir, CT
Yes. Yes.
immunography to.
Okay. Are you worried about something else?
Uh, uh, I cannot find. There is no cerebral herniation, and I cannot find any abnormal signals. So I would like to see clear sequence.
The
And papilla
patient
edema
has
is.
papilla edema,
Sir,
and
I'm
you mention this prominence of
yes,
CSF.
sir, I'm thinking
Mm.
of intracranial hypertension developing in this patient since there is a widening of the perioptic CSF spaces as well as
Maybe. Okay. Maybe. Maybe.
there is
Specific, especially, and the fossa here, the
yes,
cell here looks like
yes,
partially empty, something like this.
yes, sir,
Despite
empty.
this patient, yeah, thank you, doctor, so much. Despite the Radiopedia mentions this dural venous sinus thrombosis, in my opinion, you must say something about this perioptic prominent CSF, especially and the patient has papilledema. And here, the if you look here, the optic disc looks like bulging inside. Look here, like bulging
Yes,
optic disc. Okay, at least we must mention something about it. It may be IIH, intracranial idiopathic hypo. Mute yourself, my colleagues, please. Okay, at least if you told the examiner, doctor, I am in doubt. I'm not sure is this IIH or not. I wanted to do CSF flowmetry. I wanted to do phenography like this because in IIH, the transverse sinuses are attenuated. Okay. What is the trick of this case? Two tricks really. This suspected IIH and the lesion here. See, in the last slice. Okay, here is there are hyperdensity and you can pick up from here, but here is very clear. Thank you, doctor, so much. Last candidate. Last candidate. Mhm. Hello? Hello?
So we have two backups. Hopefully one will proceed.
I think we
Candidate
finish
7 or
our
8.
no, we
Yes, we
finish
finished
our
the
case.
6.
Yeah, this case is the case number 1. See,
Okay,
so
okay. So
no
yes.
problem. Yeah. Plus, let's meet next Wednesday. Study hard. All of you are doing very, very high effort. Viva need a lot of effort and more of luck also, both of them. So do a lot of goodness these days, my colleagues. Thanks so much really for our candidate. Sorry, of our colleagues, and special thanks for our coordinator. Anyone have any question about the cases before? I saw 12 message here. Nothing? Okay. Okay. Thank you so much. Thank you, Dr. Anam.
Thank you, sir. See you, inshallah.